Okay, good morning, everybody, again. We'll kick off so we don't lose too much time. People will be coming in from the coffee break. So welcome to part two of this conversation. For those of you that were in the session just now where we were looking at mitigation and some of the fantastic models that were emerging at this interface of increasing healthcare demands, growing impacts of climate change on the health sector, and then this imperative to green the health sector as a driver of action across other sectors as well. And this idea of identifying the co-benefits and incentivizing actors to engage in collaborative work. It was a very interesting discussion. We're going to go into part two, which is looking more at the adaptation of the sector to climate change, and recognizing, I think, something that was mentioned, I didn't pick it up when I was talking before, but this idea of the added value of the health sector in terms of the trust that people have in the health sector as drivers of change in their local community, but I also think in terms of public policy. So I think there's a disproportional expectation perhaps on the health sector to lead the way in terms of the models of interaction and the greening approaches which are economically viable and actually raise the incentive profile between institutions. So we're going to explore some of the adaptation questions in this next discussion. Thankfully, I'm not going to moderate it because I'm tired and want to sit down and listen from the floor. So Gabriel and Sean Young will be from the Hong Kong Jockey Club. Will be taking us through this conversation. Gabriel, thank you for helping out here, and Sean, and good luck.
Thanks, Doug. And good morning, everybody. You are real stalwarts because this is the happy final conclusion day, and you're still here. And this is not the closing session with all the ceremonial stuff. I see many good friends here, so it's really, really gratifying to see that you remain interested. We are actually in the second half of a twin session. So we started off with mitigation. And as, of course, you will no doubt have noticed, it's really interesting that the entire program looks at the intersectionality of climate change with health in particular, well, given it is PMAC after all. But through the first session, you really, really sort of, at least for me, gleaned an appreciation for how it actually hits the ground, especially for the concrete examples and the specific context that we learned from our speakers in the first session that Doug moderated. Now, in the second session, we are, I suppose, in my mind, is the other half of health system resilience against climate change, where the first is mitigation, or in very, very sort of direct language, is to try and reduce the impact and reduce the susceptibility. And then the second half is to say, look, if we don't quite succeed 100% in that mitigation effort, how can we adapt? i.e., how do we live with it and live with those consequences if those consequences cannot be relatively or absolutely mitigated? And I think that this subtle difference, but the complementarity of health impact and then living with the consequences of climate change as far as health goals are concerned, is really what we are doing here for this second session. We have a truly global and a metaverse of speakers today, because about half of our 6 speakers are online, and through the media here, let me just first of all thank them for staying awake. Because if you actually look, they are mostly on the other side of the world. So it's already 10 p.m. And by the time they're done, it will be midnight. So we thank them. And what we're going to do is have all 6 of the speakers, just like the previous session, give a 10-minute opening or prefacing remarks. And then we're going to open up to Q&A and discussion. I promise you, my singular goal for this morning is to get you out for lunch by 1 p.m. So that I promise you, and I will try and be as good a traffic cop as possible to make sure that that happens. So without further ado, we are going to play a pre-recorded presentation by the coordinator of the health and the environment of the WHO, Sally Edwards. I think, having had a sneak preview of her deck, I think that you will agree this is a great scene setter. So over to Sally, please.
Good morning, everybody. I hope that you can hear me and that my slides will be coming up. So thank you very much for the invitation to speak to you. And I'm sure in the previous session, quite a lot was talked about also on the mitigation front from WHO, but I really wanted to frame the beginning of this adaptation conversation from a global perspective. Next slide, please. So when we talk about the global program of work in WHO, the strategic priorities talk about the 3 billion. And the first thing I wanted to really emphasize is that whatever we do in adaptation, whatever we have to do in adaptation will impact on all of the 3 billion. If we fail in adaptation, we will have negative impacts on all of the 3 billion. So it's really very, very critical from our perspective to look at adaptation of the health sector. Next slide, please. So I'm sure many of you have seen this slide before. And when we look at climate change and the vulnerabilities, it's critical to really understand how those impact in order to make informed decisions about the best way that we can adapt and the best things that we can do. So we understand that the health sector contributes to the issue, and that is part of the mitigation, but we also understand that the impacts of it, and this also contributes to the loss and damage conversation on a more broader scale. Next slide, please. So when we look at climate resilient health systems, as we refer to them in WHO, we're really guided by the operational framework for building climate resilient health systems. And that has all sorts of different elements in it. And this can look at the vulnerability and adaptation assessments that need to be done, the health components of national adaptation plans, which are extremely essential, the health national determined contributions to the Paris Agreement. And these are all really critical from a policy level. But we also really need the integrated risk monitoring and early warning, climate-informed health programs, and also internally that there is climate resilience in our other programs, such as climate resilience and air pollution and the co-benefits that work on both these areas and the complementarity, as well as climate resilient water safety plans. And also then the streamlining of financial resources for health and climate change. And this links very much into the Alliance for Transformative Action on Climate and Health, known as ATTACH, that was launched last year, and which has been discussed at many of the other sessions of PMAC this year, and which WHO acts as the secretariat, and we really highly encourage member states to sign on and to commit, because we do believe that it touches on most of these issues and is the way where we can have coherent action together on adaptation. Next slide, please. But of course, whatever we do really needs action at an intersectoral level. We cannot act as the health sector alone. We need to link into all sorts of other sectors to be efficient and to adapt in a coherent way. In the Western Pacific region, in WHO, we're guided by For the Future, where one of the priorities is on climate change, the environment and health. And the first pillar of that priority is really bringing health, is advocacy of health outside of the health sector. So bringing health to the center of climate change and environmental initiatives. Next slide, please. And we can't talk about intersectoralness without also mentioning the One Health approach and really understanding the exposure pathways that are so critical when we're understanding the linkages between climate change and environmental impacts on health through the vulnerabilities. We need to understand these exposure pathways and their impacts, not only on biodiversity loss, but the health risks that are linked into that. And so, as you can see, this is very much linked into one of the previous slides in the previous diagram I showed. So we're, adding in an extra layer. Next slide, please. And then really lastly, to say that there is a massive wealth of information out there. 2 years ago, WHO released a compendium of actions actions and interventions that can be taken. It's a global repository. It's not only WHO, it's also got other UN agency guidance for health and the environment, but separated by issue. And of course, within climate change, it really does speak to both mitigation, but also to adaptation and what really needs to be done. But because of the interconnected nature, we also need, as I said, to really get the co-benefits, to be looking at the other areas. So we look at wash, we look at air pollution, we look at solid waste management. So to really so it filters down in between all of these interventions. So it's really looking at easy to access actions which have been shown to be effective. And so with that, I will end my opening remarks and hand back to the chair. Thank you.
Thank you so much, Sally, and thank you for staying up so late. I hope that you are in this region and not in Geneva. So moving straight on, having that great scene setter, now we're going to hear from Christine Belousova, who co-directs the Centre on Climate Change and Planetary Health at the London School. And we have a virtual presence with a video from Christine, who will be speaking on how integrated monitoring of the health impacts that is intersectional with global environmental change, drivers of these changes, and the policy responses. So over to Christine, please.
Hello, it's a great pleasure to have the opportunity to present to you today our newly funded NIHR Global Health Research Centre on Non-Communicable Disease Prevention and Environmental Change. I'm presenting today on behalf of my colleagues Vivek Jha, Chris Millett, Ali Nahid, Vidya Wengwapal, Shuyi Andrani, and many others who are supporting the centre. So why focus on non-communicable diseases and environmental change? Both are defining challenges of the 21st century that are posing significant threats to human health and sustainable development. Non-communicable diseases and environmental change are closely linked. As you can see from the deep sea diagram at the bottom of the slide, various driving forces such as population growth, increasing food demands, and technological change are leading to a range of pressures, including emissions of greenhouse gases, overexploitation of fisheries, and increasing freshwater use. These pressures, in turn, are affecting the states of the key environmental systems that are supporting human well-being and health, leading to climate change, biodiversity loss, ocean acidification, fishery decline, urbanization, and decline in freshwater availability. These changes are in turn pausing a number of exposures that have implications for human health, for example, air pollution, changes in temperature, dietary shifts, physical inactivity, and others. And these exposures lead usually to an increase in various negative health outcomes, and particularly in an increased risk and an increased prevalence of non-communicable diseases, including cardiovascular conditions, undernutrition and obesity, diabetes, and common mental disorders. To address this complex chain of events, we need actions that are multi-sectoral and also focused on health system resilience strengthening. Examples of such actions include healthy diets, biodiversity protection, freshwater conservation, and sustainable transport systems. The Centre will focus on 3 countries: Bangladesh, India, and Indonesia. These countries were selected because of the rapidly growing non-communicable disease burden and adverse non-communicable disease risk and exposure profiles that are associated with global environmental changes. So these are some of the most affected countries by environmental changes globally. We were also fortunate to have a high level of stakeholder commitment to centre objectives in these countries and a track record of collaboration with leading research institutes in these countries. So the vision for the NHS Centre for Non-Communicable Diseases and Environmental Change is to be a recognised centre of excellence on this topic in low and middle income countries. The centre will be co-producing and implementing world-leading research with local communities, strengthening research capability, advocacy, and policy for health equity. And the centre activity is structured around 3 core themes. The first theme is primary healthcare. This theme is focused on strengthening strategies that are combining digital health interventions and health workforce strengthening. These strategies will be expanded to effectively address environmental hazards and fragile health systems. The second theme are multi-sectoral actions. This theme is focusing on co-designing, implementing, and evaluating intersectoral interventions in our study countries. And I will give you more details on this theme in my subsequent presentation. The third theme is empowering people. This theme is based on a comprehensive community engagement program, which will help us understand the process and the impact of community engagement on intervention development, implementation, and evaluation. And importantly, the Centre has a strong research capacity strengthening component, which is based on a comprehensive capacity audit in our collaborating institutions at the individual, institutional, network level, and the ecosystem level. For researchers, the capacity will be built through joint interdisciplinary supervision, placement opportunities, specialized training, inclusion in leadership roles, and a comprehensive mentoring plan. Capacity for multi-sectoral collaboration and research engagement and policy advocacy will be built also in the community members and service organizations. And finally, policymakers will be building skills in the generation and utilization of lived evidence as a part of the evidence to policy process in our research and activities. So on this slide, you can see an overview of the multi-sectoral interventions that will be undertaken as a part of the Centre's work. In India, we'll be focusing on implementing environmentally sustainable changes to food aid baskets to improve dietary diversity for non-communicable disease prevention in 2 Indian states. In Bangladesh, we'll be identifying cost-effective, sustainable options to reduce salinity in water supply in 2 districts in Bangladesh. And in Indonesia, we will be testing a basket of interventions that are reducing air pollution from burning of plastic waste. All of these interventions, or all of these 3 work streams, will be structured in a similar manner. So we will be starting by describing and characterizing the relevant issues in each of the study country. We will be assessing the options for interventions, drawing on evidence reviews and synthesis, as well as stakeholder consultations and community needs assessments. And then we will be co-designing with stakeholders the most suitable intervention options. Then we will follow an iterative intervention implementation process, and we will be evaluating eventually the interventions in terms of their effectiveness, cost effectiveness, acceptability, and scalability. So now I'll give you further insight into the work that we're planning in India, as that is the work stream that I'm most closely engaged with. So in India, our aim is to identify, develop, and evaluate interventions in public food procurement systems for sustainability and prevention of non-communicable diseases. So what are public food procurement systems? These are initiatives that are designed to use government purchasing power and regular demand for food as a policy instrument to promote sustainable development. And such systems include all elements of food supply chains, from production, distribution, food processing, purchasing, preparation, and consumption. So we will be looking at all of the supply chain, as you can see on the slide, and identifying the most relevant points for intervention. But why should we be focusing on public food procurement systems? Well, public food procurement systems are important entry points that can trigger more sustainable food systems and healthy diets for a number of reasons. For example, they have a great potential to connect the supply and demand side interventions. They can help target vulnerable social groups, and such policies can have a large reach. So, for example, a public distribution system in India feeds 1 in 10 of the global population, which equates to around 850 million people. So changes in public distribution system in India can trigger large-scale benefits to health and environmental sustainability globally. And to give you insight into what issues our interventions will aim to address in India, here you can see a summary of recent dietary data from a national survey collected in 2020. The green bars here represent the dietary recommendation for each food group. The blue bars represent the actual percentage of that food group in diets in urban India, and the yellow bars in rural India. Both urban and particularly rural communities in India are characterized by disproportionately high intake of cereals and millets, and a disproportionately low intake of pulses, legumes, meat and seafood, milk, nuts, oilseeds, vegetables, and fruit. So one of our aims will be to increase the consumption of these underrepresented food groups and to reduce palm oil consumption, which is neither healthy nor environmentally sustainable. And so simultaneously, we will be seeking such interventions that help reduce environmental impact of public food procurement in India, but also help the procurement systems to adapt to environmental changes and become more resilient, therefore providing a more resilient food security function. So, for example, rice production in India is the second largest source of food system greenhouse gas emissions. So the substitution of rice with vegetables, fruits, and other food groups in Indian diets, at least partially to reach the recommended dietary guidelines, would benefit both greenhouse gas emission reduction and health. Of course, we will be seeking other ways how to reduce greenhouse gas emissions, for example, by changing transportation and storage policies in public food procurement systems. Another issue we're aiming to address is the high water stress issue in many Indian states. So our interventions will be trying to improve the balance of where which states the food gets sourced for public food procurement systems, so that we reduce the additional stress that food production can cause in the water scarce states, and make the systems more resilient that way. And we will also be trying to reduce the unsustainable use of pesticides, which can have many health and environmental implications. So overall, the anticipated impact of the center would include improved health, environmental sustainability, protection for vulnerable groups, strengthened capacity among researchers, communities, and policy makers. And thank you very much for your attention. I will be glad if you reach out to me for further information about the Centre. And if you're interested in collaborating with us in any capacity, please do let us know. Thank you.
Thanks very much, Christine. First of all, I have to apologize to Christine because I think that she's moved from the London school to Imperial very, very recently, as you can see. But it's actually only about a 20-minute drive from Bloomsbury to Charing Cross on a good day. Now, moving on to our third speaker, having set the scene with Sally, and then specific examples in a practice research context with Christine through funding provided by the UK National Institute of Health Research. We now go and really look at some examples in different countries. You will have heard from our upcoming speaker already through his intervention during the Q&A in the previous session. So please welcome Rudolph Abangnaba Abanga from Accra, Ghana. He's the Deputy Chief Nutrition Officer of the Presbyterian Church of Ghana Health Services. And he's going to be talking about decentralizing health policy from the national level and what has been happening in Ghana. So over to you, Rudolph, please.
Yeah, thank you very much. I want to start by asking a question. Can I see by hand who doesn't want to live a long life in this room? All right, I see two people. So my understanding is that majority of us want to live a very long and good life. Now, first missed opportunity. We need to brand strongly, no matter who does it, climate change as a health issue. These are the things I'm going to talk about and the role the health sector can play in especially low and middle income countries. Now, as you can see, this is something I always do when I'm doing this presentation. It is coming from my experiences. I've spoken to a lot of high-level practitioners, academics, and then when I say, okay, I'm working into climate resilient health systems, they say, wait, what exactly are you talking about? My last experience was with a colleague who was so established in public health. And then he asked me why I decided not to do public health, but to pursue environment in an environment school. I asked him, what is the whole thing about climate change? What is it about? He said, well, it's about us. We either live or we die. So again, that is the second example. Now, as you can see from here, you can see I hear in 2 successive years in the city of Accra. On my left, this was a ward that was newly established during Corona, and it was meant for isolating Corona victims. And you can imagine the triple crisis or double crisis that comes with this. You come for isolation for Corona, and you end up being threatened by a flood. But again, you can look at the cost of investments from a country that majority of our health budgets is by development partners. And then we invest so much, and then at the end of the day, then we get it destroyed by flood. The one on the right, unfortunately, it's a young doctor, medical doctor, that takes averagely 7 years to train in Ghana. On one fateful day, after close of work, after being so tired, she decided to head home to see her family. Unfortunately, she never got home. She was later found because of floods in Accra. Now, Accra is the most developed part of Ghana with all the beautiful infrastructure, not up to European standards anyway, by Ghanaian standards. And then if we begin to see this, and flooding is just one of the risks that the exposures that we have in Ghana. We have the potential to have up to 6 other exposures. So that is the situation that we find ourselves. So you can imagine what happens at the subnational level. Now, as you might have heard from the first speaker, or the one who gave the opening remarks, from the WHO perspective, you would notice that the WHO understands that health systems need to be resilient. So they have a basic framework that will support health facilities to become resilient. And they said that, okay, if you want health facilities to become resilient and then environmentally sustainable, please bring those interventions in the health workforce, the wash and healthcare waste, energy, and then infrastructure, technology, and products. So if we do enough interventions, we will ensure that health facilities are able to be resilient to extreme events. As you all know, the health sector is the one of the first responders when we have climate emergencies. They have to treat sick people, and unfortunately, they are one of the largest contributors to greenhouse gases. I learned they would have been number 5 if the health sector was a country. So now, specifically to Ghana, I try to look at how capacities over the years on climate change and health has really, really translated to action on the ground. So I would introduce you to the Ghanaian health system. As you can see, I'm sure everybody here knows that, okay, all the health systems, obviously the ministry responsible for policy. There's a second level called the regional level that's monitoring the policy. Now, this is our primary healthcare system. That is the district, and that is the basic operating unit. We have the district, where you usually have a district hospital and its management. You have the sub-district, where is the first level after the district hospital. Then we have the basic unit of our health services, which we call the community-based and health planning services. The good thing about this is that they are close to client services, and every CHIPS is supposed to attend a population of 5,000 and then or 750 households. And their mandates include close to client services. They don't just render basic clinical services, but they also move into communities. They do home visits. They also encourage community participation. Now, what I try to do, like I told you earlier, is to see how Ghana's capacity. Ghana had built a lot of capacity by 2015 on climate change and health. Interestingly, they had mainstreamed climate change and health interventions into the 2 medium-term health development plans, that is 2010, 2013, and 2014 to 2017. So the CHIPS policy, which is one of Ghana's key interventions and the most geographically spread health facility, accounting for 65% of the health facilities, that is both private and public. I tried to use that as a case study. Why? Because it was drafted in 2016. And as you can see, by 2010, Ghana was already mainstreaming at the national level. So logically, but sometimes logic is not logic, you know. One would have expected that giving birth to a very key strategy in health, this would have translated, the capacity would have translated into a lower level policy. So what did I seek to do? We just tried to do something simple. Our methodology was keywords in context. So what did we do? We just look at the keywords, we look at the context. It was used in the WHO framework, and the context, it was used in the CHIPS policy and guidelines. And then again, wherever we didn't get clarity in the CHIPS policy and guidelines, we explored other policies within the health sector ecosystem to see how this worked. So we just compared this, look at the similarities and the differences, and we drew conclusions. Now, we had over 150 codes, and then we had to make this, but for the purpose of this conversation, I just highlighted a few. You would notice that under the first category of health workforce, there are a few similarities, but for me, everything is talking about core health systems. Even though this is a close to client kind of system, it's focusing on core health systems. There's nothing about resilience there, it's very little. And WASH, you would also notice that as a standalone chips policy, there's very little. But take notice of this. I talk about the healthcare waste policy. There's also a separate healthcare waste policy in Ghana that tries to look at environmental issues. So you'd also realize that when we combine that with chips, what we notice is that there's very high interventions in the sector of WASH. Now, energy, it's minimal. Unfortunately, the first choice is the national grid, and then renewable solar, it's when you're not getting access to the national grid. And then finally, with infrastructure, unfortunately for the policy of chips, the technology they think of is a communication system, and that's basic. They talk about the standard design for chips, but again, in a country like Ghana, where we have different geographical zones, it is very difficult to use one standard design. But the good thing is that they begin to talk about taking into consideration local considerations or local capacities to manage and do this. So for me, that's a strength. But on a whole, you realize that the integration or the translation of this policy from the medium-term strategic plans to the sub-national policy has been very minimal, and then very little motivation for practitioners to move on this trajectory. Now I want to conclude, and I introduce the term thick mainstreaming. What this means is that, okay, for low and middle income countries, it's better to begin to see how you can integrate every national level policy to every small policy, and then also add indicators, monitoring, and accountability mechanisms. Why do I say so? There's too much work, little capacity at the sub-national level, and it's going to be very difficult for that health manager to think about health indicators and then possibly going to convince the district assembly to look at the healthcare waste policy, look at that policy, so many 31 policies. They can't synchronize it. It's better to put a one-stop shop that these people are able to do. Now, because we don't do thick mainstreaming, there are missed opportunities. For instance, in Ghana, the chips had increased over 63% in 2015. And this is pioneered by the local government. So apart from the national resources, there's the local government that builds these structures. And we have missed an opportunity. What would have happened? At least if they couldn't have done anything, if our policy was climate resilient and environmental sustainable enough, they would have at least constructed these taking into consideration climate change and resilience factors. So that is the first case. Number two, trust. Whilst every sector is on its knees, there is no funding or little funding at the subnational level, the health sector seems to be enjoying a goodwill. And as you can see, if people are still saying, okay, give us more health facilities, get us more nurses to give us, there's a lot of trust. Over the last 3 decades, I think that Ghana has virtually, or on the verge of, is on the verge of eliminating childhood killer diseases. We have reduced infant mortality significantly and child mortality. Maternal mortality is decreasing. So for everybody who cannot even read and write, they do understand that, well, the health sector works and they strive to go to the hospital. This is a major lever for everybody. Unfortunately, we have not considered climate change, at least in my country, as a health issue. But this is a big lever that we can rally the health sector, get everybody on board at the subnational level to implement, coordinate, and then run sustainable programs. Again, there is the political capital. There is the Member of Parliament's NIA fund, National Health Insurance Fund. So the National Health Insurance thinks that, okay, every Member of Parliament should be given some amount of money to run an intervention. So these are resources that are available for intervention. And if these were integrated, then we could get that opportunity. Now, even without any backing, any policy backing, we find autonomous interventions. winds destroy health facilities. I met a district director who told me that, look, I had to buy trees to give it to them to go and plant at all the health facilities. That is autonomous. They are already tackling it by themselves. But if we do take mainstreaming, we are going to give the opportunity to them to be innovative, autonomous adaptation processes will come on and then will work well. Now, importantly and finally, the health sector, I know most countries, low and middle income countries, are running a primary healthcare system. And this comes with community health systems alongside the formal health systems. And then for Ghana specifically, there is a developed system at the primary healthcare level. We have what we call the Intersectoral Committee of the District Health Management Committee, the District Health Committee, that has already got all the important players at the local government level. They are meeting on a regular basis. Unfortunately, they are responding to emergencies on a knee-jerk basis. But we can also use this opportunity to let them plan and implement resilience interventions. And then again, these do not just stay at the district level. At the community level, we have what we have to call the community health management committees. We have a network of volunteers. At the sub-district level, there are committees. These are all structures that can be leveraged along with the trust to ensure that climate action is sustained at the sub-national level. Now, finally, the biggest miss is that CHIPS has got three components: clinical outreach and then community engagement. Every year, there is the training for health staff to be able to run this. Why can't we just integrate interventions of climate change into it? Now, there's this constant outreach and community engagement. It again provides us the lever to get other professionals use the back of this to move on. Thank you very much.
Thank you so much, Rudolph. Most helpful, if you would just like to take a seat. So Rudolph has really concretized the previous two talks by showing us CHIPS in his country, Ghana. And now we're going to move on to learn about more countries. And we're going to hear case studies from Georgia, Lebanon, Mozambique, and Costa Rica from Julia Lofreda. Julia is working at the Queen Margaret University in Edinburgh in the UK. So over to you, please, Julia.
Thank you very much. Hi, everyone. So today I'm going to share with you my experience with using complex science and theory to actually support better understanding of the system and better understanding of the links that exist between climate change and health, and how this actually can help us to develop intersectoral policies and adaptation strategies. So I've been using complex theories and science and system thinking in my work with non-communicable diseases, and now more also with climate change. We, in this particular project, in this research project, we wanted to map the dynamics that exist between climate change, health, and other human systems. And we started doing so by developing our theoretical framework, or what we call a seed model. Basically, we develop and define the three dynamics, the three key variables, such as the state of the earth, the human health and well-being, and human-made influence activities. And we define how these three variables interact with each other. This was also based on literature. And then after that, just a quick snapshot of the methods that we used. We conducted a qualitative mixed method approach. So we reviewed the literature based on climate change, adaptation, and resilience, and specifically for the case studies that we're looking at, such as Lebanon, Costa Rica, Georgia, and Mozambique. We reviewed the literature, we extracted the data, we defined the key themes that emerged from the literature. And After that, we develop our initial causal loop diagrams, the initial maps, with all the variables that we found in the literature and the dynamics among those. And then we conducted some consultations with stakeholders in each country. These included experts in health, climate, and environmental issues. And with the stakeholders, the consultations were conducted online, and we call them group model buildings. It worked quite well, also conducting them online. Usually we have been doing this in person, but I think it worked well also online. And with them, we cleaned the models, we refined them, and we finalized them. And this is basically what's the final result. I know it's a bit complex and it's sometimes not easy to read, but the idea is to really provide an idea of the complexity of the system. So in blue, you can see the variables that we consider to be like the key threats for climate change and health. And in red are the variables that we addressed as being as resilience and adaptation strategies. So just to give you an idea, I'm going to just give you again a snapshot of these models. For instance, in Georgia, we discussed how air pollution, it's actually a key issue in the country, and how these interact also with other environmental pollutants, and how, for instance, it's also associated, it's a well-known association with respiratory diseases, with coronary heart diseases and other cardiovascular diseases. Air pollution is actually getting more political attention in the country, and a health impact assessment was actually underway while we conducted this research. Also, we discussed, for instance, the impact of heat waves, an increasing concern in the country, how this is associated with mortality rates due to cardiovascular and other pathways. And then we discussed some of the adaptation strategies. For instance, the importance of capacity building, and Georgia introduced planetary health education for medical students. Also, we discussed how the country set up a coordination mechanisms and a task force to support coordination across sectors, actors, NGOs, and different ministries. Now, moving to Mozambique. In Mozambique, a particular issues that the participant highlighted was around water management and water resources. So Mozambique is prone to both floods and droughts due to the phenomena of El Niño and La Niña in the north and in the south. With regards to floods, here, this variable here, this actually poses quite a serious threat for the ability of the country to manage the water resources, and also impacts water and sanitation here, and increasing the risk for infectious diseases, diarrheal diseases, and other outbreaks. Also, we discussed another issues which is linked to the topography of the country, and being very prone to the risk of sea level rise, which is causing actually coastal erosion, and then also putting pressure on community livelihoods, the ability to farm and to fish. The quality of the housing also emerges as a very important factor, mediating the impact between climate change and health. Also, other factors associated with this were migration, also linked with unplanned urbanization. Some of the adaptation strategies that we discussed were pretty much linked, again, with what I mentioned about coastal area management, early warning system, maintaining system for coastal ecosystems, producing data, and disaster management and prevention. Also around urban planning, and what was called and highlighted as the political security of water, because Mozambique is also receiving quite a large amount of water from neighboring countries. Lebanon now. What emerged from the discussion and from the literature was issues related to the geopolitical instabilities of the country and the region. So, for instance, water conflict were addressed as having actually an impact on environmental degradation, on the living conditions of the local population, and then impacting human displacement, which itself then can have an impact on water and conflict. And what I mentioned just here is what we call in a feedback loop, which actually can be reinforced. So the variables can actually reinforce themselves in a vicious cycle. So it's quite important in causal loop diagrams and system thinking to actually address those feedback loops, because we can actually, if we act on one of those, we can actually try to break this cycle. In terms of the adaptation strategies that emerged, were, for instance, discussions around agricultural practices, developing more promoting agroforestry and agro-silvopastoral system, community-led solutions, also to support food security. I'm going to skip Costa Rica because just too much information. But so what emerged then, it's that, so what I show you were kind of contextual specific characteristics of these countries, but definitely there emerged that also there were commonalities across all those settings, across the adaptation, across the pathways, the dynamics, and the adaptation strategies that could be developed. So these are just an examples of the 5 adaptation strategies that emerge from all these contexts, such as the importance of early warning system and preparedness, strengthening health system resilience, urban planning, social security, and adapted agricultural practices. Just to conclude, I think I want to share with you, I think, the use and the opportunities that these type of methods provide as a tool actually to conduct consultations at national and local levels, using the approaches that are informed by system dynamics to really identify the interlinkages and then develop intersectoral policies. Again, these tools also should be complemented with the analysis on power. Also, for instance, social network analysis can also, it's another system thinking tool that can be used in this sense. And then adaptation strategies need to consider upper investments, which prioritize social security of vulnerable community and population, which are the most impacted. And it is an issue of social justice, like broader social justice issue. We need to focus on strategies in general to strengthen health system resilience, and need to consider the relevant capabilities and a whole system transformation. Also, data monitoring is very important, which needs to be prioritized from all the relevant sectors, particularly from the private sectors, which can be sometimes quite reluctant to share data. I stop here.
Thank you so much, Julia. Really, absolutely fascinating methodology. You come at it from a system policy perspective with system analysis and these complex diagrams, but indeed very revealing, and a lot of new insights. And of course, there's been in the last decade or so the popularization of similar looking diagrams, but not nearly as complex in the epidemiology field, of course, of causal inference and directed acyclic graphs. So not only the intersectionality of social topics, so health and climate change, but the intersectionality of methodology or techniques of analysis is something that has always been fascinating and illuminating. Now, you also concluded in your recommendation slide, and you alluded briefly to the issue of social justice. We're going to come back to that in the 6th and final talk. But before that, we're now going to move on to yet another context, yet another country. We're going to hear from Jit Sohal, who is Regional Program Manager on Climate and Health for Southeast Asian region. And we're now going to look at the case study of the Danagat Islands of the Philippines. So how does climate resilience in not the best functioning and quite frankly fragile health systems using the Danagat Islands of the Philippines as an example? So over to you, Jit, please.
afternoon. I'm Jitsuha from Healthcare Without Harm, Southeast Asia. And we work with the health sector in transforming them to become low carbon, sustainable, climate resilient. And I am honored to be with you today and to be able to contribute in the conversation of health adaptation in the context of climate change. So as you mentioned, I'm going to talk about the case of the Nagat Islands, Philippines, and how discussions on building adaptive capacity of in decarbonizing health systems rarely acknowledge that half of the world does not have access to essential health services, and that over 100 million people are pushed into poverty annually because of health expenses. Next slide, please. Further, a large number of health facilities are not connected to reliable energy and water sources and are in perpetual state of stress. So when a climate shock strikes, it is not a question of whether fragile and collapsing health facilities will bounce back or transform, but whether they will continue delivering services during crisis or ever fully recover. So what does it really mean to build resilience in those settings? So the province of the Nagat Islands, next slide, is a geographically isolated island province located in northern Mindanao, bounded by the Pacific Ocean on the east. Next slide, please. Yeah, with a population of 128,000 people spread across 7 municipalities and an internal revenue allocation annually of less than $5.4 million. The province has a lot of geographically isolated communities located in both coastal areas and in the mountainous areas, and is very vulnerable to different kinds of climate hazards. Similar to the situation in the rest of the Philippines, the local government functions are devolved. That includes provision of healthcare services. So you can imagine how challenging it is for healthcare workers, healthcare providers, as well as other workers in the various offices dealing with social services to address the concerns of the population on such a limited budget. Their healthcare capacity is quite limited. For the longest time, they only had 15 doctors for the entire province. They only have 3 district hospitals and 7 rural health units or frontline health facilities. Those health facilities deal with primarily with preventive care and primary care. The district hospitals address urgent care patients requiring hospital admission. However, those hospitals do not even meet the requirement or the standards of the national government to be even classified as a hospital due to the lack of equipment and personnel. So they're only really accredited as an infirmary. Just to give you an idea, they were only able to acquire and operate an X-ray machine for the first time for the entire province on December of 2021. Before that, patients requiring imaging, those requiring operative care or intensive care, they had to be transported to mainland Mindanao, which is an hour of boat ride away for the main municipality. But for further municipalities, it can take up to 3 to 4 hours of boat ride for patients needing care that the province couldn't provide. So although I'm focusing on the context of the Nagat Islands, this is not unique for the province. There are similar situations in many other rural areas, geographically isolated areas, not only in the Philippines, but in other archipelagic areas with isolated communities. And this lack of access to secondary and tertiary level of services, as well as the limitations due to the lack of personnel of preventive healthcare service, lead to poor health outcomes in the entire province. For instance, in 2021, the rates of chronic malnutrition are high. Around 15% of children less than 5 years old in the province are reportedly stunted. 1.5% of children less than 5 years old were reported to have moderate acute malnutrition and 0.34% severe acute malnutrition. And then 20% of the households have no sanitary toilets. So as a baseline, even before they were hit by any major disasters, their healthcare system was already struggling and very fragile. A lot of people living in the province are unable to finish secondary education even, so they have limited number of homegrown health workers, while those who are not from the island are generally not inclined to work in a geographically isolated area. And then you have local leaders who don't understand really the importance of preventive care, of improving access to healthcare, improving public health services, and implementing public health programs. Next slide, please. Next slide. Yeah. there. The province is not only vulnerable to the impacts of climate change because of their low adaptive capacity, but also because of their geographic location and terrain. They're prone to flooding, rain-induced landslides, sea level rise, and they're located near a fault line. All typhoons that enter the Philippines from the east, from the Pacific Ocean, pass by the province. The incidence of extreme weather events, such as the one that hit the province last December 2021, are increasing and leave the island communities far more vulnerable to these events than they were in the past. But also, aside from these, man-made activities such as intensive mining that lead to environmental destruction that further exacerbate their vulnerabilities to impacts of climate change. Next slide. So when Typhoon Rai in December 2021 hit the province, it affected more than 90% of the island. The destruction of boats, ports, and other transport services meant that for a few days, they had no immediate access to relief from the rest of the Philippines. And so their immediate concerns after include access to food security, access to clean water, sanitation, shelter, and of course, the continuity of health services, since most of the hospitals and healthcare facilities were likewise affected by the typhoon. So the lack of access to these basic necessities led to immediate and long-term health consequences. Like the increase of incidence of acute malnutrition almost doubled. They saw outbreaks of various infectious diseases, not just COVID, but also acute gastroenteritis due to the lack of access to safe drinking water. And people actually died after the typhoon because of that. And then you have long-term health effects like increases in chronic morbidities, lack of control of chronic conditions such as hypertension and diabetes for people who were unable to access their routine healthcare services, unable to go to their community health centers, or even ask for their maintenance medications, unable to see their usual physician because there's no transportation or the roads are still not passable. And then, of course, you have the mental effects on the entire population that include even the health workers that provide the care. Next slide, please. So these are just photos of the hospitals and rural health units that were damaged by the typhoon. 90% of all of the health facilities were destroyed. And only one district hospital was not completely destroyed, and that they continued operating out of a corridor in the kitchen there. They continued seeing patients and at one point had 40 plus patients in that tiny room that you see on the lower left photo. They continued providing sexual and reproductive health services in rural health units. And there was one story that was shared to me by one of the rural health workers that they were delivering a baby while rain was pouring in the partially destroyed room of the health unit, which is dangerous for both the mother and the child. Almost all equipments have been damaged, limited pool of health workers who were already stretched too thinly because they were also victims. Healthcare Without Harm, next slide, worked with the Provincial Health Office of Dinagat Islands last year. Next slide, please. To help understand and address some of the needs for recovery of health facilities impacted by the typhoon. They realized that this is not the last time that a similar or stronger typhoon will hit the province. We're still living in a pandemic. We're living in a world with continually increasing temperatures. The incidence of extreme climate events will only increase unless drastic efforts are made, not just at the level of the provincial government, but also in terms of our national health system. So resilience to climate change of a health system like the one in Dinagat Islands need to consider both adaptation and mitigation actions. Like you said, Gab. At Healthcare Without Harm, we believe that climate resilience requires a holistic and innovative approach which encompasses both mitigation and adaptation strategies and policies that reach wide into the community and the enabling environment. When adaptation and mitigation are combined, these strategies can aid in identifying the greatest climate vulnerabilities and sources of emissions, facilitate the prioritization of programs and investment areas aimed at addressing both, and encourage innovation and ingenuity that will enable the transformation of their system into a climate-smart, climate-resilient healthcare. For the province of Dinagat Islands, they have identified a couple of priority actions, part of a set of building blocks that will lead them to become resilient to future impacts of climate change on their health system. And these are just some of them. I'm going to share them. Climate change adaptation of health need to be mainstreamed in local plans. Hazard maps and vulnerability assessments need to be updated and consider impacts of climate change on health and health systems, which should then guide the local government in prioritizing and implementing adaptation actions. So this is really a collaboration between health office and environmental office and planning office, which, to be honest, most of the time really doesn't happen. Adaptation actions should not just also be focused on structural, whether health facilities are located in areas that are going to be below sea level in a couple of years, or is it typhoon proof, or have access to clean and safe water facilities, but also should look at non-structural or behavioral adaptation actions. Local leaders need to be aware of the intersection of climate change and health, of environmental management and health, how to manage the environmental resources, including but not limited to oversight and governance of mining activities which contribute to habitat destruction. The government, both at the local and national, should address the issue of health inequities that are exacerbated by impacts of climate change, and prioritize adaptation actions that will build resilience of primary care facilities, because we know that will save lives. And health professionals have an important role in addressing or advocating for this. Healthcare professionals need to be trained on the realities and impacts of climate change in their role in addressing these climate disasters, in not just in immediate response, but as well as in prevention, in building awareness, in maintenance of environmental health and sanitation, and in climate advocacy. Healthcare professionals, especially doctors and nurses, are one of the most trusted communicators. Their communities follow their advice, and politicians and leaders listen to them. So, for example, the doctor we work with in Dinagat is capitalizing on that power and advocating for the prioritization of the health system resilience in the province, starting with sustainable healthcare waste management and advocating for transition to more clean, renewable energy. And lastly, financing for all of this is critical. And for a local government that is already struggling, how can you expect them to fund these? And that's where we need to work with national government, with funding organizations, with the private sector, and international organizations like the WHO and UNDP. Next slide is my last slide. This is a figure that came from our partners from Dinagat Islands. They look at building resilience at these 3 levels. And at the facility level, we need to build adaptive capacity to ensure continuity of public health services and quality care in our communities. A focus on building adaptive capacity and resilience of our primary health centers is necessary for highly vulnerable communities. At the community level, local governments need to initiate community-wide interventions to reduce the vulnerabilities of disadvantaged communities to disasters, climate-proofing infrastructure, building back our communities better, safer, and healthier. We cannot just build resilience of our health facilities. Our communities should be able to safely access these services during and immediately after extreme weather events. At the system level, we need to address the issues of inequity stemming from environmental, economic, social, and intergenerational disadvantages that can be amplified by climate change and extreme weather events. The health sector as a whole has a responsibility to address environmental justice and climate and health inequities. We cannot talk about building adaptive capacities and resilience of health systems without talking about universal health coverage and climate justice. The situation in the Dinagat Islands is similar to other climate vulnerable countries or communities not only in the Philippines. Our contribution to the crisis is almost negligible, but we bear the brunt of these extreme weather events. I'm going to end there, and thank you so much.
Thank you, Jit, for joining us remotely. And you have, in your final slide, just like Julia, have given the perfect lead-in to our final, but certainly not least, presentation, because it addresses the fundamental driver of the inequitable health impact of climate change. We invite Montira Pongsiri, who is Senior Advisor of Climate Change and Health for Save the Children. Montira, the last time that we Zoomed with each other was, I think, for Rockefeller Boston U Commission. So we've got to meet in person sometime. But thank you so much for talking about how in the adaptation of climate change for health resilience that you think we should look at the equity angle. So over to you, Montira.
Thank you, Gabriel. I don't see the slides yet, but okay. Thank you. Thank you. Swadee Ka. My name is Montira Pangsiri. I'm very grateful to Mashida, Doug, UNDP, and PMAC organizers for the invitation to join you today. It's really a great honor. As you all know, climate change has the potential to disrupt the progress of humanity because it affects the provision of our food, our safe water, and clean air on which we depend, and because of its potential to exacerbate already existing socially mediated risks such as displacement and limited access to essential health services. I think we all have a common interest in mobilizing science for impact through informed decision-making, policy, advocacy, and solutions on the ground. I think how we do this is important for achieving that impact over the long term. So what I'm going to do is share how we at Save the Children are addressing climate and health, describe the systems-based approach we're taking, how this is operationalized, and then follow with a few examples. Next slide, please. Addressing the health impacts of climate change is critical because climate adaptation and mitigation planning by countries cannot ignore health. Doing so could result in trade-offs and unintended consequences, which could ultimately undermine our well-intentioned efforts to improve health. Next slide, please. Climate change increases inequities in the present and for future generations. The risks to health posed by climate change are the product of the nature of the hazard, whether it's extreme heat, drought, or floods, the extent of exposure to that hazard, and underlying vulnerability, which depends on factors such as existing health status, socioeconomic status, and access to health services. These vulnerability factors are compounded by social determinants, such as inequalities associated with gender norms, roles and relations, race, ethnicity, and disability. Next slide, please. For Save the Children, climate and health is a climate, health, and equity challenge. One challenge. We're interested in who is affected, how, and why. What are the types of adaptation interventions which can strengthen communities' ability to track, anticipate, prepare for, and manage climate-related health risks? Next slide, please. The magnitude of climate-sensitive health impacts depends on the climate actions taken now. There is urgency. This figure shows that climate change interacts with social stressors to affect health. Some of these social stressors are modifiable, such as socioeconomic status, access to health services, housing conditions, access to clean water and sanitation. Accelerating and amplifying efforts to address the social determinants of health can reduce the negative impacts of climate on health. So, adaptation strategies should focus on practical approaches to effectively sequence and integrate interventions that address the range of context-specific factors contributing to adverse health outcomes, from the upstream drivers such as climate change and increased exposure to related hazards, to the underlying structural inequities, such as unequal access to services and to infrastructure, to the more immediate consequences of increasing stress on scarce natural resources, for example, conflict and displacement. Next slide, please. Many determinants of health fall outside of the health sector's responsibilities, such as activities in energy, transport, and agriculture. They contribute to climate change and at the same time affect health. The relationship between climate change and health can be nonlinear. It can involve time delays and feedback interactions among many factors. This complexity can lead to health outcomes which are hard to predict and result in unintended consequences, including disproportionate adverse effects on underprivileged groups. As a result, a multi-sectoral systems-based approach is needed to address climate and health. A systems approach to climate and health helps us to see the big picture and understand interconnections between the drivers of climate change, their impacts, and any feedback relationships which could amplify negative impacts on health. These interconnections are really important for identifying root causes rather than symptoms. Root causes that we can target for positive change while minimizing the potential for adverse consequences. The key to operationalizing a systems approach to climate and health is the integration of knowledge on climate, its health impacts, social, and other sectoral determinants which affect this relationship. Next slide, please. Specifically, integrating these data from across sectors and disciplines into policy tools to support assessing vulnerability, routine monitoring, forecasting, and taking cost-effective actions to reduce the health risks of climate change. Next slide, please. We are operationalizing a systems approach to climate and health. Our objectives are to sustain health, recognizing that health depends on this condition of our natural systems, such as our climate. To target climate drivers also, and the social determinants of ill health that drive health inequity. And our objective also is to support multi-sectoral governance inclusive of community engagement. Next slide, please. What we do has to contribute to the evidence base for underpinning strong adaptation strategies. Research and learning questions for us are central to the design, how we partner on, implement, and evaluate our activities. Next slide, please. These are the impacts that we are trying to achieve through the systems-based approach. Stronger health systems with the capacity to track, plan for, and respond to climate hazards. We want to support communities with the capacity to prioritize their health risks. And we want to support the development of national and subnational plans that reflect an understanding of climate, health, and equity interconnections. And through this, we'd like to see voices of children and women and underprivileged groups amplified in policy and advocacy discussions at multiple levels. Next slide, please. How do we get there? We think we get there by overcoming the key barriers to addressing climate, health, and equity together. For example, to overcome limited awareness that there are common drivers of climate change and health, we will improve understanding of the multisectoral impacts of and interconnections between human activities, climate, and health, as well as the social determinants which contribute to it. To address inadequate recognition of co-benefits of actions on climate and health, will foster community actions to identify and test interventions at scale. And to break through decision-making silos, we're supporting multisectoral governance through the use of integrated decision support tools and data. And then to increase the participation of communities, we're strengthening skills and leadership capacity of communities to engage in the co-design and the co-implementation of actions. And finally, to increase human and financial resources for climate and health, we're developing multiple benefits-based advocacy to engage the public and private sectors. Next slide, please. Wanted to end with a few examples of our climate adaptation and health activities. In Niger, we're integrating data on household economies, cost of the diet, drought, and malnutrition risk to inform the development of early warnings so that governments can prepare for and address food and nutrition insecurity through improved cash transfer and other programs to improve the quality of the diet of children and families. In Somalia, we're piloting the use of wind generators at health facilities, which will provide clean energy to heat water, refrigerate vaccines, and we're supporting jobs to maintain this system. Later this year, in 3 countries in Asia, East Africa, and Latin America, we'll be working with community stakeholders and government representatives across sectors to build systems maps of climate, health, and equity interconnections. using these maps as a basis for identifying priority actions to reduce climate-related health risks of most concern to them. Next slide, please. Thank you very much. I'll look forward to our discussion.
Thank you so much, Montera. So we now go to the Q&A and the discussion. Because half of us are here in person and the other half are actually online, maybe could we not show my face, but actually the other people who are actually online, so that we can have a conversation. Is that all right? So we should have Sally, we should have Jit, and of course Montera, who just spoke with us. Well, while we wait for the audio-visual system, there they are. Thank you so much. Now, what I would like to start off with is to follow up on the equity and justice topic, which of course Montera was just speaking about and also alluded to at the last slides of our previous two speakers. Let me just go to Montera and ask you, how would you try and do adaptation when, as you've shown, there is nothing quite so toxic as the toxicity of poverty as far as climate change impact is on health? And could you maybe just elaborate a little bit more on those 3-4 examples that you gave in your last slide, so as to contextualize it for us?
Make sure you can hear me.
Perfect.
Okay, thank you. So yes, addressing, I think, inequity is critical to how we do health adaptations so that we don't leave anyone behind, and particularly pay attention to those most at risk of these impending dangers. I think the figure that I showed of the spectrum of intervention points to address, to target our interventions, I should say, to address climate, to better manage risks, will be, I think, a combination of strategies to not only to better manage the effects of climate change better, but to do what we already have to do in providing healthcare, strengthening our health systems as a climate adaptation strategy. So the tools that I mentioned that are needed, that depend on our integration of knowledge on climate, its stressors, its health impacts, and the social determinants which intersect with them, are going to be necessary in order to bolster those tools that we need for assessing vulnerability. Who's most vulnerable? How and why? And not only to do vulnerability assessments, to do that routine monitoring that we have to do to be able to assess over-changing environmental conditions, what that portends for specific health risks. So we need a strong and robust data set of different types of data that are integrated to be able to do vulnerability assessments, to do routine monitoring, but also to be able to forecast, to the extent possible, the health impacts of a changing climate. Because those health systems with updated information systems must be able to better prepare and anticipate and manage health risks of a changing climate, particularly for those most vulnerable populations, which need to be accounted for in all of our national adaptation plans, including health national adaptation plans. So the way that we integrate, and I keep coming back to the word integration, because underlying that is the multi-sectoral collaboration and multidisciplinary collaboration that will be needed, because it takes different types of data, climate, health, and social, to be able to populate not only our own understanding, but the tools that are necessary for assessing vulnerability, for forecasting, so that we can develop strong, robust, evidence-based climate adaptation strategies, especially for those most vulnerable in our communities, and do it in a way that involves community engagement so that they co-design and they co-implement those adaptation strategies for their benefit.
Thanks so
Maybe
much.
I'll yield here. Yep.
Yes, thank you. Thank you so much, Monteria. It sounds extremely similar to the conclusion of the commission that we both served on, the 3D Commission, Determinants, Data, and Decision Making. And it's very interesting that, in this region, there was, pre-COVID, a health justice panel or commission that was spearheaded by the CMB, Lincoln Chen, and his successor to be, Roger Glass is here. Many of those commissions actually sit here. It's co-sponsored by Keiji Fukuda, who was the former director of the Hong Kong U School of Public Health. Tim Evans, I see, he was part of the commission, and Suet is at the back in the other corner. He also was part of the commission. So I very much hope to see follow-up of this in due time. John G. from Tsinghua University has been standing there at attention. Please go ahead.
Thank you, Gabriel. I really enjoyed this session. It was great to see a diversity of evidence from around the world. My question is regarding new adaptation indicators that we can measure and track. And I ask this question because the big project I'm working on right now is an invited series by the Lancet Western Pacific to make a report on adaptation for each country in the Western Pacific region, including China, Australia, Vietnam, etc. And when I look for evidence, right now, if you look at the Lancet countdown indicators, there are 5 adaptation indicators. First one is information system. Second one is air conditioning. Third one is urban green space. Fourth one is funding. And the fifth one is emergency management. Among these, air conditioning and urban green space are the ones I like the most, because that's something as a resident you can take action on. And those have been measured. Air conditioning is measured by the number of air conditioning units per 100 household. For urban green space, it's measured by normalized differential vegetation index, which is a satellite image of the green space coverage in the area. Now, I want to challenge the speakers. What are some of the a new adaptation indicator that you think we could measure and look into in the future that may have emerging epidemiological evidence right now that we could get started on, so that we have more evidence in the future? Thank you.
Thanks, John. Who would like to take that on? Maybe should we go back to you first, Sally? You gave us a very high-level overview. Great scene setter. What does the WHO Health and Climate Change Program look at in terms of these impact indicators?
Thank you. And I think that this is a very key discussion at the minute, because it's actually a discussion we're having internally, as well as, what would be useful to use as indicators, because it's not only about disease outcome, because we don't view those as necessarily particularly good indicators of our efforts and what we're trying to do. I do think that one of the discussions is around early warning systems, and actually having an indicator related to functioning and efficient early warning systems being in place that are impact based. So are based on the relationship. They're not just purely environmental early warning systems. And things like that, I think, can be, as we move to some of the more complex diseases, such as, everything related to heat, everything related to drought, infectious diseases as well, could be an indicator which could be applied across the board as being something useful. But it is a discussion, and it's very interesting to hear that we're not the only people having this discussion internally as well, because trying to create something that is applicable across the globe is really complex. So you mentioned, for example, that related to air conditioning, or the use of air conditioning in certain contexts is really not applicable. So how do you make the discussion really a global discussion, and an indicator should be global in its usage? So that's where we are, and the challenges that we're having with really moving forward with this.
Thanks so
Thank
much,
you.
Sally. Those of us who actually attended the impact measurement session yesterday afternoon would have really benefited from that rich discussion as well, for those of you who were in that parallel session. Before I come to Tim, who is very patiently waiting at the mic, Montira, you have your hand up.
I do. Thank you, Gabriel. I just wanted to add to Sally's response on early warning systems. It's important to have those in place, and it's also important to measure how they're used. So, for example, I have an example of a project that Sally, Jit, and I actually are developing with the government of Laos to produce early warnings of vector-borne and waterborne diseases such as dengue and diarrheal diseases. This climate adaptation strategy, by updating health information systems, is supporting the government's efforts to better serve the health of their rural communities who are most at risk of a changing climate in Palau, PDR. So how the early warning alerts are used there are really important for us, and a major component of that work. And the utility of those alerts will be enhanced through social behavioral strategies, which will complement how those alerts are mobilized and translated into action. So I just wanted to add that the utility of those alerts are an important indicator. And in addition to that, I think the community engagement, models for community engagement on identifying the types of climate and health risks most important to them are really important. So for me, Julia's presentation really resonated, because those kinds of systems, maps, models, and diagrams, which may look very complicated, are really produced with communities to identify their shared vision of what they want for the future by understanding what their climate drivers of their most important health concerns are.
Thanks, Montira.
I'll yield there. Thank you.
Tim.
Thanks very much, Gabriel, and thanks to the presenters. Fantastic presentations. I'm wondering if you have any views on the extent to which the human resource is either there in abundance and with the appropriate competencies, or perhaps a constraint. And if you could speak to it perhaps across the various areas that you were talking about. For example, do we have an abundance of complex systems modelers that are really going to illuminate local context in a way? And do we have people who can manage to get to the most remote areas of big countries and actually walk the talk on some of the strategies that might be emerging from community engagement on what needs to be done? So I just would be interested, and in particular, if you had any recommendations for laggard institutions like mine, which don't do enough, in my view, on this front in terms of mobilizing the human resource. So if you have any recommendations on that front, I'd love to hear them. Thank you.
Thanks, Tim. So shall we just take Tim's question first, and then we'll come back for the next question. Julia, wonderful, wonderful methodological technique, really innovative, really at the cutting edge. Tim is asking, well, great, but can we roll this out? And in fact, COVID is a perfect example. I mean, there are, a handful of really good modeling groups around the world, but there aren't enough of them for the last 3 years. And even when their results were correct, the translational process into policy and the so-called right decisions, that was another gap. So what about health and climate change?
Yeah, thanks so much for the... Is it working? Yeah. Thanks so much for the question. I wanted to start maybe with slightly reflections on the capacity in general that are needed, and maybe just shifting also the focus on capabilities, and just try to pick up the critique from Marta Nussbaum and Amartya Sen. So how we are using actually the concept of capabilities in also applied for climate change and health. And it's not just what we can, the capacity that we have and we are, but also what we can have. And these are also linked with thinking more with a complex mind about the relationships and also the interests that are present at the level, and how those also interests interact with each other, and dynamics in the system. And in terms then of the capacity, so definitely I think we need to develop all this technical capacity. And it's not just about research methods, it's about also the leadership, the broader technical skills, but also how we navigate power dynamics in the system. So particularly when we talk about intersectoral collaboration. And so I just...
Thanks, Julia. Can I pick your brain, Rudolph? Tim says CHIPS is great, but do you have enough people to devolve down to the very, very, very local community level?
Yeah, I think that we are already moving towards that trajectory. This is what has moved us on. Very few countries are not decentralized, and then again we need to learn that the people know the system very well, and then we only need to catalyze them. They are already feeling the heat, and then again, once they are feeling the heat, and then we manage to get them actively participate, then this leads to people-led movements for change. So for me, the most important thing as any organization that's working internationally or globally, you need to reach out to local partners. When I say local partners, people who understand countries, provinces, and institutions to lead the way. Unfortunately, there's abundant capacity, but we don't use them. For me, capacity is about knowledge of my community. It doesn't matter whether I have been to school, I understand our frameworks or not. So on a whole, I think that humanity has lots of capacity to deal with this, both formally and informally.
Right, I see, Jit, you want to jump in there before we move on to Dr. Nansai?
Thank you. Just really quickly, I just wanted to also highlight that that's a really good question. And the Alliance for Transformative Action for Climate and Health that Sally mentioned earlier is actually acting as a convener of all of these technical capacity that are available to support countries and health systems in building both climate resilient health systems, but also sustainable and low carbon health systems. And I believe they're trying to put together, resources, whether technical and potentially even financial resources that countries can tap to capacitate their communities and local governments in doing whether it's vulnerability and adaptation assessment or HNAPs or and any adaptation actions and resilience building in health systems. So I just wanted to point that out, that WHO is actually leading that one.
Thank you. Thank you. I think that the issue of capacity building in intersectional fields such as this one, which is so critically important, when we know from the WHO that HRH as an issue has always been a huge problem, even for the most basic direct service delivery needs. That's absolutely critical. Sally, you want to jump in?
Just very, very quickly to add, there's also, as part of WHO Academy, some courses on climate change and health, which take it from a broad angle, trying to increase capacity in various different aspects, and they're free online resources for people, because we do recognize that we do need to build knowledge and build capacity at all levels in these areas. So, from really strong data management, data analysis through everything. Thank you.
Thanks, Sally. Kazuki Nensai from Japan. Dr. Nensai, you've been extremely patient. Over to you, please.
Thank you. Okay. So my question is to the speaker. Oh, sorry. Working? Okay. My question to the speaker is vulnerability of the trade. So by the climate change. So this is in terms of the adaptation point to check. So I think I like to ask about the international trade. For example, last year, 2 years ago, I forgot. But anyway, there was a big flood in Thailand, right? At the time, Thailand couldn't export the parts for the automobile. Therefore, Japanese company had stopped their production of automobile. We can wait for getting an automobile, right? Even though 1 month, 2 days later, we can be patient. But if there's some country or they can't produce the pharmaceutical anyway, or clothes for medical equipment, so we can't wait because somebody may die. Yeah, therefore, how we should adapt such vulnerability of the international trade regarding medical or things, or maybe that such disaster will happen to other country, not to their own country. What do you think about this kind of the adaptation?
All right. Who wants to address that? Montera, you look pensive, deep in thought. You must have something to share with us in response to Keisuke's question.
Thanks, Gabriel, and thanks for the question. I'm not going to have a full satisfactory answer, but I think climate adaptation through health system strengthening should include that component. Really explicit attention to community level services, actors, and partnerships is part of an important climate adaptation strategy through the provision of primary health care, which will depend on a reliable supply chain. This is one aspect of the Lao project. I mentioned that we're working on with JIT and Healthcare Without Harm and with Sally at WHO. We're looking at the commodities that the Lao health system relies on as part of a forward-looking approach to strengthening health systems to be more resilient to climate change. So that's certainly under consideration within our project. But I don't have enough expertise to tell you the component parts of that.
Great. Thanks, Montera. what I'm going to do is take a final couple of questions because we only have literally 5-10 minutes left. Pooja, do you have a question? Oh, Anne. All right, so why don't we do Anne, and then Pooja, do you also want to ask? So we'll go Anne, and then Pooja, and then KG, all right? And then we'll answer all together. So Professor Anne Mills from the London School.
Thanks, I'll be very brief. I wanted specifically to address Julia's presentation, but it's also a more broader point, which is these complex systems analysis, causal loop diagrams are really helpful in identifying especially these sort of upstream indirect determinants, but they end up in a mind-blowingly complex set of relationships. And as an economist, my question is, what about prioritization? And so I have two things. One is interest in, is the work going beyond the narrative description through to some sense of quantification or weighting of the different dynamics going on? And then how do you end up from that process with some decision on which are the key areas, which are the most important, not what is everything, but which are the key ones to focus on and act on? Thanks.
Thanks, Anne. Xu Fujie, who's the head of health for Gates China.
Yeah, I also want to add it to how we frame, the risk. And, I'm an epidemiologist by training, so I kind of quantify the risk as my specialty. But I want to share one example. In China, back in 2020, a storm knocked out all the electricity in a city called Taizhou in Zhejiang province, where I worked. And actually, by design, they knocked out the city, the electricity supply to the whole city. But in one hospital, in the dark background, one hospital's lights is still up. The reason is because they have a backup electricity in the basement, but they also have backup electricity on the second floor when they designed the hospital. There was with a winner of designer from Japan, as a very famous designer for the hospital. So that kind of example, I don't know, as an epidemiologist, I don't know how to quantify that kind of risk and with that kind of response. So I want to share this and challenging, to my challenge to the panelists here is that how we prepare uncertainty like that maybe one, like 200 years or 100 years, what have you, but by simple thinking, I think change in the design of the environment, the hospital can actually do a good, you get a payoff and big in the end. Thank you.
Thanks, Fujie. And not least, finally, Keiji Fukuda.
So, Gabriel, I have a bit of an observation and maybe a challenge. I don't know, do you want to address the questions first? Or do you want
No, you go ahead, and then we will answer all of them together.
Okay, well, so this goes back to Tim's question about capacity and manpower. But in my time in public health, I cannot think of another issue which has galvanized young people as much as the current debate on the environment and diversity and so on. And I think this is manpower and capacity building at its most fundamental. This is what WHO, when I was there, we've all struggled to do and never really succeeded that well. And I think the practicality of the issue is that it is incumbent upon all institutions to figure out, how do you bring in more young people, much more? How do you harness that energy? Because that energy is there, and it's really looking for a way to enter the discussion. And it's a very concrete issue for institutions to address. And so I want to put that in front of everybody.
Thanks so much. So we have 3 very, very deep but impactful questions. So KG basically says, look, HRH, Human Resources for Health, is a huge issue. And in fact, I suspect the reason Tim, who is now left, asked it was because he was smack in the middle of it. He was instrumental in part of that first report on HRH. And so was Roger's predecessor, Lincoln Chen, and Sudhir Anand from Oxford. So how can we leverage on that experience, but also look at climate change, which is what drives young people nowadays? Can we address that for KG? And then really it's a measurement issue for both Fujie and for Anne, who basically said, look, there are a million things that we need to do, but how do we prioritize? And I suppose anybody who does corporate ESG reporting, which is now de rigueur for all of the major stock exchanges, will do and advise, and that's the materiality assessment. What is there that really is meaningful material, and what are the key things that one must look at and focus on for each corporate? But now take a 35,000 feet view. How does that work for the whole of society? And similarly, how do we reward, and therefore we have to measure, health facility resilience, which is what Fujie asked. So I'm going to just go round to all of you. You have 40 seconds. Otherwise, these people are going to go on hunger strike. So why don't we start with Julia, and then we will go with Rudolph, and then we'll go online.
So shall I address Professor Mill's question?
Oh, you can pick any question you wish.
Yeah. So I totally agree with you, and I found myself overwhelming those type of diagrams. So what I found them particularly useful actually for the process themselves, the opportunity they provide to actually for the stakeholders to sit together and to find an agreement and to find a consensus. So really for consensus building and find the links and the dynamics and having a really good understanding of the systems. Also, they can be used. It's also important when building these models to define the boundaries. At one point, you need to define where the system starts and where it ends. You cannot include everything, otherwise it will be just impossible to read. Also, I think we can also, it's possible also to prioritize. I think the purpose is to prioritize with the participants, right? So your stakeholders, the policymakers, and all the people involved. So I think that's part of the process, the prioritization. And also for quantification, I think it's possible, what I show, those are qualitative models, but it's possible also through transitions to quantitative models and use data and also develop more system dynamic models and what we call stock and flows models. So that can also be used for prediction purposes. Yeah.
Thank you. Thanks for keeping to time. Rudolph, 40-second starts.
Yes, on a highway, I'll start by my highway example. There are some cars that can go at 150 kilometers per hour. Others go 30 kilometers per hour. By the end of the day, the most important thing is for everybody to get to their destination safely. So for me, issues of uncertainty exist. And we must be mindful that not everybody is at the same level. Exactly why we need to engage and engage well. And then again, take advantage of investments. What are we investing today? We can't overhaul the whole system, but at least we are always making new investments. Can we deliberately make those investments very, very resilient? And then finally, I like to say that integrating is very key. We've always had problems with human resources for health, but at least when COVID came, we didn't say we didn't have human resources. We rode on the system. So can we keep on riding on the system as much as possible?
Thanks, Rudolph. Now, just on my screen, let's go from Jit, and then we go to Sally, and then we wrap up with Montera. Over to you, Jit. 40 seconds.
Thank you. I'm going to answer the last question regarding youth and involving youth in the issue of capacity for health systems. We have in Southeast Asia what we call RAI, Southeast Asia Alliance for Health and Climate. And really our goal here is to bring in health professionals, including emerging healthcare leaders, youth, medical students, public health students together, and become advocates for climate change, build their capacity as climate change communicators and advocates, and also support communities and health facilities and health systems in transitioning to more sustainable, low carbon and climate and future. So that is something that we at Healthcare Without Harm really believe in. in engaging the youth. And actually, majority of our members are youth, and they engage with community. They visit communities that are impacted by climate change. They visit communities that are impacted by fossil fuel-led air pollution, and conduct medical missions, but also engage with policy makers and leaders at the local and national and even at the global level to raise the issue of climate change and health in climate vulnerable countries like the Philippines, Thailand, Malaysia, Indonesia, etc. So that's it.
Thanks, Jit. Sally.
Thank you. So looking at the question about resilience of the health system, I think that it's really important to take a systems approach to it, to found it on evidence, doing the vulnerability and adaptation assessment, so we're really sure of what we can expect, but also what we might expect, what is projected to happen, and then use that in designing new, doing retrofitting, doing work so that we do get climate resilience built into our health system. And that's not only at facility level, but through the whole system. So it takes account of sustainable procurement and procurement systems and shipping, that it goes all the way through, that we use evidence first and then go from there in a very systematic systems thinking way. Thank you.
Thanks, Ali. And not least, final word.
Thanks, Gabriel. I just want to put in a plug for implementation research because we do have a lot of gaps in how we design interventions and how they are successfully implemented. So there's more and more awareness that there needs to be investment in implementation research to assess how we design interventions and how conditions on the ground should enable them to be successfully implemented.
Thank you so much. And I promise you that I will make sure that you don't go hungry. But before we all disappear for lunch, let me just thank again UNDP for putting this morning together. Doug was the mastermind and Mashida was an absolute stalwart throughout the preparatory process. And on a more personal note, for the Jockey Club Charities Trust of Hong Kong, Sean, who sits in this front row, he has been the hero. I am merely the front. So with that, please thank all of the panelists in the metaverse as well as in person, and give yourselves a round of applause. Thank you very much indeed.